obviously that we're running slightly later than the timetable schedule, but that's absolutely fine. And indeed, a lot of what we would have covered as an introduction to the background about GMHAT has been covered a lot in this morning through the excellent presentations we've had. So we will go through that, but we'll go through that probably quite quickly, really, because we can just link it in with the discussions we've had this morning. And before we get going, I thought it'd be helpful for the three of us. You can see on the program there's three of us who are with you this afternoon and tomorrow, just to briefly introduce ourselves. So my name is Matt Bowen. I'm a senior lecturer at the University of Chester, and as I said briefly this morning, I've worked with VML for the last 7 years around education and training, and I'll just hand you very quick.
There's one, two, one. Thank you, Matt. I'm Soumya Krishna. I'm a psychiatrist, consultant. I used to work in Chester, and I moved back to India in 2017. I'm based in Bangalore, where I have an independent practice. But I've kept in touch with the GMHAT team and have been helping with the training. My association with GMHAT has been since my trainee years, for almost 14 years now, and that was in different shapes and forms that I've been associated. So it's a pleasure to be with all of you. Hope we can help in whatever way we can.
Thanks, Soumya. Before I introduce myself, I think it's important that we're from nursing, we're from psychology, and we're from psychiatry. So we've got a wide range of professions working in the training of GMHAT. My name is Stephen Jones. I'm new to post Professor of Mental Health at Chester University. Clinically, I've worked in prisons, police, probation, inpatient units, brain injury. But I think what's important is that beware, you've heard that we've had experiences about 14 years working with GMHAT. It becomes infectious, you start to want to use the measure, you start to want to do research, you start to want to work with other professions. So there's a word of caution for you.
Thank you. So this first introductory session was aimed really to give some context to how GMHAT arose. But as I said, actually, a lot of that we looked at this morning, so we will still do that, but we'll touch on it quite lightly. And then after that, all of the PCs have GMHAT downloaded onto it. So we'll move quite quickly into getting you to open up the GMHAT program, and we'll do sort of a walk through about what GMHAT actually is about, just the structure of it. Some of you may well be familiar with it already, but we heard it spoken about a lot, as Steve said, in a sometimes quite infectious way this morning, and I imagine some of you are quite curious about, well, what actually is it? So that's the first part, and then we'll have a break for tea, and the second part will be actually seeing a video consultation and just having a go. So this is the outline of our sessions for this afternoon and for tomorrow, and it's very much about two components really, probably more than that, but two fundamental ones. One is actually having an experience of using it and having an experience of some of the issues that we're raising around communication and around questioning skills. So it's very much experiential and role-play based, and also about constructing an open dialogue within the room, because it's evident from this morning there's a lot of people doing a lot of work. There's a lot to learn from each other. I have a very narrow experience of this. Many people have many other, and collectively we have a very varied range of experiences. So hopefully we can use the time as much as possible to draw on that depth of knowledge. As I said, I wanted to kind of just present something about that global picture, about why GM Hat arose. But, as I said, a lot of that is information that we've covered this morning, so I think we can move quite quickly through that. But right from the get-go, I suppose, some of the key issues is just how significant mental illness is as a global phenomenon. So, obviously there are challenges around the accuracy of data because of some of the issues that we touched on this morning, and mentioned again here around how large the gap is between the need and met need and assessment. But our understanding is that something in the region of 1.1 billion people globally are affected by mental illness. So we're talking about something that has incredible significance as a global issue. And across that, a number of different disorders obviously are more or less common, with depression and in fact mixed depression and anxiety being the most common. Professor Gupta this morning was talking about disability-adjusted life years, and we'll see that when we think about mental health in terms of that, and again, this is a very significant globally in terms of total disease burden. Of course, that varies from country to country, but in no country is it not of considerable significance. And fascinating presentation by Professor Verheer this morning specifically about farmer suicide, and of course Catherine Robinson talking about their project, Sashi, looking at creating networks to try and think about how to better understand, ultimately to try and address suicide more broadly. And we know that there is a relationship between mental illness and suicide. They're not the same, it isn't only accounted for by mental illness, but in this, the significant factor, I suppose, is that here we see this strong association between the level of mental illness and the level of suicide within nations. So there seems epidemiologically, bigger picture, there seems to be a relationship between the level of mental illness within the society and also the rates of suicide. And when you break that down, we also know, as was mentioned by Mohammed earlier, that, for example, depression is a very high risk factor. So we know that there's an association between the prevalence of mental illness and suicide, but we also know that that varies depending on different disorders as well. And so for major depressive disorder, depression, that actually the level of risk is almost 20 times higher for somebody with that diagnosis compared to the general population. And for somebody with a diagnosis of schizophrenia, about 12 times higher. Likewise, for other disorders such as borderline personality disorder, is quite common. So again, the significance is about the point I'm making is that mental health disorders are significantly prevalent within society globally, and their impact is both in terms of adjusted living and also in terms of suicide as well. And sadly, what we know is that whilst there is a significant need, there's also, as was mentioned several times this morning, a significant gap between the level of the need and that need being met. Hence the whole drive from the World Health Organization to try and address that mental health gap. And that is common across a whole range of different disorders. So it isn't just about a particular area that is particularly problematic, but actually across a whole range of different disorders we see this significant gap. And we see this significant gap in terms of people having their needs met, and then also in terms of the assessment. So a failure to assess that need, which is part of the challenge that we have around identifying just how significant the need is. And again, we see that that is a pattern of a global nature. So the failure to assess the limitations in the accurate assessment of people who have mental health disorders is something that's both global and also across a range of different disorders. And the reasons for this obviously are very, very complex, but one of the points that this slide is highlighting is that part of that seems to be about attitudinal issues as well, and linked to that is that there are issues around stigma and attitude, relevance of stigma. So stigma in terms of the impact of people's having inaccurate knowledge or poor attitude and the actions that inform that, how that affects people generally, how it affects health clinicians, how it affects people who work, live in society, how it also affects people who have a mental health disorder or who may start to worry that they have problems around their mental health, and how they might respond to that. Maybe respond to that in a way that's different from how they might respond if they start to worry about their physical health. That maybe there are concerns around stigma and how somebody might be treated that might inhibit somebody from seeking out help. Certainly that seems very relevant in the UK. Would I be right in saying that that's relevant in India and other countries? It certainly seems to be. It certainly seems to be the case that it prevents, because it becomes a barrier for people to seek out support when they themselves maybe start to worry about their own mental health, or indeed if other people start to worry about it and report back to them. And the focus for the conference is around primary mental health, and of course we know that mental health care, mental health need is very prevalent and very relevant in primary care, but of course globally, and certainly to speak from the UK position, historically mental health resources have been very much focused at secondary level care. And so there's a huge amount of need at primary care level that hasn't historically been the level of investment. So, very briefly, I'd say that they're the sort of the key points, issues for why GM-HAT arose, because of this very complex, very significant, and persistent problem. And I think that's one of the issues. I think, going back to the issue of stigma, one of the things that is almost curious about it is the fact that that seems to be relevant across the globe. It's a social, it's a cultural phenomenon, and it seems that that's relevant across the globe. And and there is a persistence to this as a problem to be addressed. So that's the context really in which GMHAT, Global Mental Health Assessment Tool, aimed specifically at primary care, arose. So what did it do? So look, we heard a lot this morning about different people talking about different studies, and they're talking about comparisons, about people using the GMHAT tool, and people being trained to do it who aren't professional, mental health practitioners who aren't psychiatrists, and being trained to use the tool, and then comparisons going on. Well, actually, if the same person's being assessed by a psychiatrist and they're being assessed by somebody who's used the GMHAT tool, are they coming to the same conclusion about whether there is or whether there isn't a mental illness present, and what the nature of that is? And that's, at the heart, I suppose, of that assessment tool that the tool provides. It provides an opportunity for somebody to address that full range of presenting problems and systematically consider these in quite a simple and straightforward manner to support the person who is making the assessment to come to a conclusion about whether or not there is a mental illness present, and if so, what might be the nature of that. And so it addresses this sort of full range. One of the perhaps differences about the tool is the fact that its global aspect is both because of the global picture, but also because it does address that broad range of mental health disorders rather than focusing just on one particular. And this is just an example of a screen, so it's just a screenshot. Won't be showing many of these because we'll just have a look. We'll put the program on in a minute and have a look through it. But, this is just an example of the tool directing you to ask questions around mood, whether somebody has experienced depressed mood, and questions that you are directed to ask specifically related to mood. Have you felt sad or depressed recently? Have you cried at all, felt like crying? And is depression there most of the time, or just a few hours at a time? So questions that are directing you to issues directly related to depression, and also directly related to gathering information about, well, how long has this lasted? What's sort of the duration? What's the impact of this? So it's taking you step by step through, so that you could start to feel confident about, well, actually, yes, this is maybe present now, but how significant is this? So we'll show this as we'll go through the program, and then at the end of the program, at the end of the assessment itself, the program generates a computer-assisted diagnosis, and you'll see that it covers this whole range of different areas of anxiety, and mania, and eating disorder, and depression, and psychosis. So it's giving you feedback on those different areas, and then coming up with what the computer feels to be its assessment. But really importantly, within that, you've also got here about clinical judgment. And so it came up this morning, so I was saying that Well, actually, there were I believe, and you said this, there was a couple of people, there was 3 people who had anxiety and it wasn't being identified by the tool, but the clinicians felt that actually it was present. And it was an interesting discussion about, well, actually, is it more important, and it's arguably a mood, isn't it? Well, it's a balance. Is it more important that we don't over-diagnose, or then are we leaving it so that people who should be receiving treatment aren't? But one of the important factors in that is that the person themselves felt there was a problem. And so that is this very significant bit around actually what's the clinician's assessment as well. And it's really important that that's there, because this is a tool rather than a robot that just does something. So this is very much there to assist. It's very much there to direct and to direct questions, but it's not there as the master for you to just say, okay, now if the computer says it's this, and end of story. So the whole point about it is that it is directing you to consider a whole range of different issues that are relevant to mental health. And one of the things that you'll find is that actually there'll be questions there that you think, well, actually this isn't relevant to this person. I'm asking somebody a question, no, this isn't relevant to them. But you've asked, and then you've made sure. It's very easy for us to assume that something isn't relevant. And that's part of the problem, isn't it? That it's very easy for us to assume, oh, well, this doesn't look like the sort of person who would have a problem with drinking alcohol. They don't look like the sort of person who have a problem, because I have an idea in my mind what that person might look like. But actually, by directing us to ask that question, it gives us maybe permission to ask. You might say, well, look, I'm going to ask you this question because the computer here is asking you to say, can I just ask you, do you drink regularly? And of course, that could be another example of where it's maybe taboo around that. Again, Professor here was saying, actually, in his study, alcohol is a very significant factor in farmer suicides, but it's dry safe. So there might be questions that we feel we assume aren't relevant, and the program might direct us to ask. But likewise, we're still at the very heart of it. So at the heart of it, it's for us to also feel, actually, this is my belief. This is helping me, but this is my belief. And that might be very relevant when you're thinking about how do I, for the questions that are asked, you make a decision about whether there is any evidence that there is a symptom, whether any evidence that the person is depressed, whether there is some, but actually it's only very mild, or whether actually there is some and it is presenting a considerable distress or severe distress. And you're making that judgment, and that again is the decision that you as an individual make. And that's part of what we'll discuss over this afternoon and tomorrow. But it's an important part to get across that this directs us, but we're not a slave to that. And there might be occasions, in this example as well, where you ask somebody, how's your mood, have you felt depressed? And their initial response might be no. but actually their face looks flat, their head is down, and their body language to you doesn't look like somebody who you think, no, their mood is light. And that might encourage you to ask more, but that balance might think, actually, yes, this person, on further inquiry from my own experience of them, they seem quite light. An assessment tool, but the other thing that it is a great resource about mental health disorders and appropriate treatment and care. And that's perhaps the first thing that we'll look at when we put the programme on. Because it's the bit that doesn't get spoken about as much, because obviously the heart of it is about the assessment. But it's a fantastic resource because as we were discussing this morning, we're often thinking about, well, who is it who might find this particularly helpful? And often it is going to be people who, no, they don't have a depth of understanding about mental health disorders and treatment, and then need to be able to access that knowledge in situ when they're doing it. Okay. There's so many studies that are going on. I just put this one up, which Vimal touches, and the suitability. But again, I think in many ways it's something very similar, talking about people who are working in healthcare, who are used to being with people, who are used to having conversations with people about their health and well-being, and maybe are concerned that there's something else that's going on, that maybe there's something else around that person's mental health, and they know they don't know enough to know exactly what it is, but maybe have quite a lot of experience to know that something isn't right. And I think that's an example of where this tool can fit in very, very well. And again, we know that the tool is being translated through into a wide range of different languages, so that it really can be a global tool. Okay, we're going to, in a moment, get to put the programme up and have a walk through that. But before we do that, just throw out if anybody's got any immediate questions from this first brief introduction. Yes?
Is it possible to get the actual scores in Excel file or later if you want to analyze the data?
Yes.
Is it possible?
Yes, explain.
We get it, sir. We get the data in the Excel sheet for all the clients.
Yeah, so embedded in the tool, it's a great question, and I love it because it's a great example. So we kind of concentrate on the tool to get to an endpoint of diagnosis, but there's actually a lot more embedded in it. And one of those is that you can store all of the histories of previous GM hats for the same client, so you can then plot those changes, and it can do that automatically. Okay. I've just got one question here, and
How long does this assessment take? That 30-day duration.
So the question was, how long does the assessment take? And the studies that we've done have been suggested about 15 minutes. But you kind of expect that initially it's longer and it gets a bit quicker. And in fact, the 2 video consultations that we have are a bit longer than that. But the studies suggest, on average, about 15 minutes.
what I mean to just clarify that as you also mentioned about the different fields in which we have to get the data, and the data has to be fed in the computer for the assessment. Am I clear to you? I mean to say that we will have to first take data of the individual person, and then we have to fill in the format to do the further analysis.
Yes.
Okay.
And is there also a format developed so that accordingly the data is to be captured from the field?
It is there, sir.
It is there.
It is there. You have to give some demographic information like gender, name, address, contact number, email ID and all, and with whom he is living and all that information, basic information has to be fed. And then of course you have to feed the this one. As we go ahead with this, as we walk along with him, you will come to know. We have to give some information which is identification information, then the presenting complaints of the patient and how long the patient had problems, that we have to type, and then later on you have to just click on after asking the question, which scoring, just scoring is there.
Thank you.
Hi, my question is around the ownership of the data. So, all this while that you've allowed this free tool to be used at various places and countries,
Yes.
what has typically been the model of ownership in the terms of, I'm curious about the privacy aspects of it. For example, in US, I know that if you visit a GP around mental health, etc., your records will never be released without your consent. But is it a standard practice even for this tool, or it depends on whoever is implementing it?
Yeah, it depends on its use. I mean, it's the
Your
tool.
data will remain with you only, ma'am. I'm sorry, I'm interrupting.
Yeah.
Your data will remain with you. They will give you the password. With that password, you only can retrieve that data.
So
But
there's
the
no
institution
central.
that is, say, tomorrow if say this institution, okay, it implements a program where it's training health workers to collect this data.
Yes.
Now, apart from the patient itself, I would assume the institution also has
Yes.
ownership of the data, right?
Yeah, I mean that would be so the tool itself has no central mechanism to gather and hold that data. The tool's free to download, and then each institution or individual would be following their normal governance and confidentiality. This would just slot with it into that.
But the manufacturer, like you will not have the access.
No
to the
access.
data.
No. That's a really important point.
Yeah.
The tool is downloaded, and it is for individuals or organisations to use. The data is not put onto any central database. We have no access. We're completely blind.
So we need a permission, like from your side, to download the tool or not? Like,
No, just complete a form. You complete a form online. It asks you for some information, just so that we're plotting what different professional backgrounds are using it, what institution, asks for an email address, but there's no condition.
but I hope like you have made a set of rules who can use it, like those who are trained in this can use it, or like is there a set of rules, or anyone, any lay person, any random person can use it?
Well, I mean, any random person could use any copy of any paper tool they wanted to. I mean, no, I mean it is a good point, but the reality is the tool is free and available for an individual to download as much as it is for an organisation. So no, it isn't restricted to app.
It came to my mind because
Sure.
MHGAP, you need a training to diagnose and stuff to do. Like a lay person will not be allowed. Like they will be allowed, but it will not be taken seriously if a layperson diagnoses using MSCAP.
Yeah.
So
The same is true with this, what happens, you can download, anybody can download it. Even the mentally ill patients, they can download it, see their own assessment. But they are not very well trained, they may do some mistakes, at least well trained. So it's free, they can download it. So this is some, customers raise many places that abuse of this system. But because they are not trained, they cannot exactly pinpoint the diagnosis of difference and diagnosis.
In addition, your data will not be merged with the other person who is doing that. Like two systems, two people are doing.
Yeah.
Your data is with your professional expertise. The other person is whatever he is doing. Your data will be your own. That data will not get mixed with yours.
So even if somebody diagnoses, you won't be able to certify, you won't be able to treat unless he is a professional.
it's like hats and other things.
So they will download and assess themselves, but they won't be able to treat anybody or they won't be able to do anything with the data.
To be honest with you, GML is an extra advantage that you can see the notes, you can talk to the memory members and they complete. It's not only the interview of the
Few questions you have to ask to the relatives only. The patient himself may not be able to tell.
What you have is a few important points. GMHAT is free to download at source, like Matt said.
Yeah.
Somebody's mentioned about the training. I think if you're going to get increased validity and reliability of any measure, then a consistent training helps with your core values, your delivery. We're developing a 1.5 day package that you're going through now. Most are very experienced, some might not have experienced GMHAT here, so it's very hard to pitch it for all of you. That's why we thought it would be very practical to structure the GMHAT and go through it so that we can offer some consistency, at the very least, to the group here. Some of you are probably going to go on, if not already, and deliver GMHAT and train your colleagues in it based upon these materials. We will gladly make these materials available to you. So training, consistency and structure are important. But the last point is about GMHAT and the time frame to complete it. You're all busy professionals. You all have varying amounts of time to deliver your objectives in your role. What I would say is that we would not like it to become a mechanistic yes, no, 3, 2, 1, you got a 3, therefore you got major depression. For those of you who have done depression inventories, you maybe don't tick every box. It becomes part of your interview, and after a few, you know the questions on the depression inventory, and you structure your clinical judgment according to that. So you know the markers, you know the scoring system. So we're not going to get hung up on the scores or the training. It's the communication you have with the person during the assessment that these might uncover some things that you might want to explore. So some of you might take 15 minutes, some of you might take 30. But what it shouldn't be is a measure that's just administered to get a score. I'm sure we all have to agree with that. That becomes, I mean, in the UK, there are some health trusts that rely on some measures to give a score that would get somebody admitted to hospital. There are also some measures that would give a score that would allow funds to be released to that health trust. For me, that defeats the whole objective of having a measure if the value is on the score. Is that kind of okay with where we stand on its use?
Okay, so one last question and we'll confirm.
Diagnosis is combined with the ICD testing.
Yes.
So now the ICD level is coming up, so the few disorders, new disorders are introduced. So is there any further updates can be expected?
Yes. Now I was expecting a question about ICD-11 and I'm glad we got it in within an hour because I had a bet that it would take between 2 and 3 hours. So I'd actually really have to defer to Vimal on that. I think that I would anticipate that the program will evolve, but obviously I'm mindful of the fact that it is based on ICD-10 and I anticipate that it will evolve to incorporate any changes relevant to ICD 11. But I'm not sure how many would be directly relevant to certainly for the core of the program.
ICD 11 is not coming in another 2 years.
Yeah.
Because in DSM-5 they are seeing that lots of difficulty and confusion going on. So their waiting is watching it, and then they will improve it. So just wait for 2 more years to go.
Yeah.
So you are comfortable for 2 years.
Yeah. At least. Thanks. Okay. So if it's okay, we'll move on to looking at the program. So on your screen, you should have a GM-hat square, shortcut to the GM-hat. So if you click on that straight away, and I'll try and find it on my screen as well. Okay, so we'll just give ourselves a minute to make sure that everybody gets to that first opening screen. Okay. Is everyone there just on this first opening screen? Yeah? Okay, so this program, this is the English version, so just click continue. Nothing else, just click continue. And that should bring you up that. Okay? Okay, so before we start the interview aspect, consultation aspect, first we're going to have a look in the care pathways section. So at the top here we have care pathways. Okay, so click on that. And that PDF document should open up for you. Okay, so click onto Care Pathways, and this opens up a PDF document that's just there permanently embedded into the GeoMap program. Like I said, this is a great resource for people to use when they're initially familiarising themselves with the program. It might be that one of the advantages of the free access is that individuals themselves can go away. If they've completed training and then they want to continue to familiarise themselves with that, actually they can do that for themselves and carry on learning. But it's a great resource that's just always there to be made access on. So, what does it cover? So it starts off with some information about some of the general principles, and then moves into looking at specific disorders. So if we just scroll down initially, so that first initial information is about how important it is that somebody's had physical examinations. Because of course we know that there are some examples where people's physical health can easily, and often does, get causes maybe a state of confusion that the person may be brought into hospital and there's concerns about actually is somebody experiencing a mental health problem because actually they've an infection that's causing them to be in a very confused state. So the first component is directing people towards an examination around physical health. I've gone back up now, and what you'll see is that each of these are. So I've gone back up to the beginning of the document, and you'll see that each of these are hyperlinks, so that you can quickly navigate your way around rather than having to scroll through. So, for example, if we select one of these disorders, so if we select depression, so we saw on an earlier slide that globally depression has the highest prevalence, so it's going to most scenarios, most situations, it's going to be you're going to work with people with depression more than any other diagnostic group. So that, if you click on that, it takes you directly to this information about depression. If we scroll down, so if we scroll down, it gives some general information about the care and treatment of somebody with depression. It starts to help inform us about what some of the treatment options are that are relevant for people who are experiencing depression. and some of the important skills that are necessary. So, building a trusting relationship in an open and engaging, non-judgmental manner, exploring treatment options in an atmosphere of hope and optimism. So really bringing home how important the soft skills, the interpersonal skills, the skills that are we maybe at times take for granted, but actually are perhaps even particularly and especially important when working with people with mental health problems. And so scroll down further, so it's talking a little bit about sort of some of the more the sort of general approaches, and then thinking about what is this guidance on different treatment models. And of course, as you become more familiar with it within your own particular context, you start to think about that, and then how does that translate to the services that are available within where you're working. But what it does is it's giving you some information to start to think about the different types of options that might be more suitable, and different types of options that might be more suitable depending on how severe the problem is. And you'll notice that I'll try and make this a bit larger. You'll notice that there are quotations in here, directions for what you should say. And it might seem like, oh, isn't that a little bit too prescriptive? Isn't that telling us a little bit too much about what we should be saying? But of course, this is only advice. It isn't saying this is what you must say. But the reason and rationale for giving that level of detail is just to try and direct people and, in a way, take their hand to say, look, this is what you could say. These are the kind of words that you could use. Because I'm sure you've all found that actually you learn an awful lot from seeing people who do something well and taking in how did they phrase that. That was a really adept way of wording something that was quite difficult to say. And this is sort of giving you some tips really about how you could articulate. And what happens is that you then define your own particular way. But it's just trying to take somebody by the hand. Then in this example, it has some examples related to depression of different antidepressants that are relevant, are evidence-based, and then other psychological interventions that are evidence-based, and other areas around provide social support. Sorry, I should put my glasses on this time. This time I'll actually press the button. Okay, so if you close down the care pathways, there's a lot there to explore, but just trying to, apart from anything else, encourage you to explore that. It's one of the things that's embedded in it, and it's a great resource, but we kind of quite quickly kind of cut to the chase. So, close down that, we'll reopen the actual assessment itself. So let's first add a client, and then we'll have tea break. Okay, so if you go down and add a new client, and then we will now just take a few minutes, and I think the boxes are quite self-descriptive. Add the name, forename, surname, gender, date of birth, and complete the boxes for a fictitious client. So just anybody's name, anybody's address. Yes. So for NHS number, just leave that blank. Just leave that blank. Has everybody completed their data? Okay, so then save and update. Okay, so save and update. They'll ask you twice. Whether you really want to save it, just carry on saying yes, save. Okay. Okay, so I haven't got this far. Let's take a break and have some tea, and we'll come back and we'll move through it. Okay? Yes.